Welcome to MenopauseWize, your go-to podcast for all things evidence-based in the menopauseverse. I am Dr. Sukhpreet Patel, an MD gynecologist, a menopause health advocate, a postmenopausal woman, and the founder of MenopauseWize. And I'm so excited to have you join us on this journey. Whether you're a healthcare provider looking to stay on top of the latest evidence-based practices, a woman navigating your own perimenopause or menopause journey, or a partner or family member eager to support a loved one, this series is designed with you in mind. Our mission through MenopauseWize is to close the menopause knowledge gap by bringing you the latest research, expert insights, and practical advice, empowering you to make informed decisions about menopause and perimenopause. Do a quick introduction. The quick one will probably not do justice to Dr. Desai's work, but I'm just going to make it brief. Dr. Chintan Desai is a leading shoulder surgeon and a sports medicine specialist, and he's recognized for his expertise in the region of the shoulder joint, specifically, and he's involved in advanced arthroscopic procedures, treatment of the frozen shoulder, and everything got to do. He's the shoulder guy. He's also the only Indian doctor invited by the International Olympics Committee for the Winter Olympics in 2018. That was quite something. And he is currently practicing at many different hospitals, including Breach Candy, Jaslok, and Saifi out of Mumbai. So that's him in brief. So thank you, Dr. Desai, for joining us today.
Thanks for the kind introduction, and looking forward to throwing some light on the shoulder. I hope the viewers of your show understand a lot more at the end of this.
I'm sure they will. I'm sure they will. So let's get started with, we've always known, from med school, little bit that we learned, or I learned about the shoulder joint, was that the frozen shoulder is more common in women, and it is more common in this age group of 40 to 60 years. Also recently, very recently, frozen shoulder has been added as one of the conditions included in the musculoskeletal syndrome of menopause. And most of our listeners are, they're basically here because they're impacted by some way by menopause. So can you tell us what exactly, let's just start off with basics, because sometimes, just little movement is affected and sometimes we call it frozen shoulder. What is frozen shoulder to begin with? Let's just start with the basic question.
Frozen shoulder, let me be honest, is still an enigma. I mean, we still don't understand perfectly why exactly a frozen shoulder happens, but definitely there is a metabolic cause to it. The commonest being diabetes and hypothyroid patients are commonly associated when a frozen shoulder patient comes in. That's the first thing we check, and most commonly they do come out to be positive. But frozen shoulder, any pain in the shoulder doesn't mean a frozen shoulder. That is what I would want to impress upon your listeners. That the reason that the patients experience stiffness in the shoulder can be varied. It cannot necessarily mean that metabolic cause is the cause of a stiff shoulder. In our world of shoulders, we label patients as having either painful stiff shoulders or painful non-stiff shoulders. So patients who have stiff shoulders can have stiffness because of any reason, and frozen shoulder is just one entity amongst that. So purely a frozen shoulder, which is labeled then as an idiopathic frozen shoulder, there is a reason why it's called idiopathic, because it clearly throws light upon us idiot doctors that we don't understand it. And that is absolutely true, that in those patients we do not know a real cause as to why it's happened. And when we go digging, then yes, we may find that there are small labrum injuries, small muscle injuries, upon investigation, that maybe is the reason why their shoulder has become stiff. So when a patient comes to me with a tight, stiff shoulder, I first label or categorize, flowchart them as to, is there any source of injury? If not, then I go on to investigate them metabolically. And menopause, yes, is recently coming up to be one of the primary reasons why these patients are developing frozen shoulders. I think it can also mean that aging women with once their estrogen levels go down, osteopenia or bone weakness or osteoporosis starts happening. But before osteoporosis happens, the preceding uh, uh, problem is sarcopenia, which is muscle weakness. So muscle onset of muscle weakness is first, followed by osteopenia, which is bone weakness, followed by osteoporosis, which is extreme bone weakness. So in my practice, I find that patients mainly with sarcopenia or early onset of aging start developing weakness in their muscle, and with simple household activities tend to develop these rotator cuff small injuries, and frozen shoulder sets in, which is a stiff shoulder sets in, which is kind of like your body's protective mechanism to hold. It's like an internal brace that is going to protect your rotator cuff tendon to allow it a chance to heal. So it's your body telling you do not move your shoulder anymore, because then your tendon is going to get more injured and probably then lead to more problems.
Understood.
So frozen shoulder is, I feel, like an internal brace. That's what I would want to impress upon your viewers.
So basically, your body is protecting you from injuring it further or getting worse. So it's restricting your movement as a guarding towards it.
Yes.
Uh, right? Okay. What when we want to diagnose the reason behind the frozen shoulder, you mentioned idiopathic, and idiopathic for the listeners basically is, as you said, the doctors haven't managed to find any reason, any underlying condition which has caused that frozen shoulder. How does one then know that it is idiopathic versus not idiopathic? There is a condition. You also mentioned that metabolic conditions. So metabolic conditions would be things like diabetes, and some kind of it could be menopause, it could be thyroid disorders. Say we've done all of this. Patient is, or the woman is not diabetic, doesn't have a thyroid condition, is perimenopausal or menopausal. What would be your next step in testing this woman? What would you recommend?
Yeah, so generally patients come to me as a shoulder specialist only when they have gone through the whole gamut of treatment options, doing physiotherapy, exercise, and they are not improving with just that. Mind you, most idiopathic frozen shoulders do improve with time, in the sense that if their diabetes or sugars get corrected, they experience less pain. Thyroid improves, their range improves. Similarly, there is a recent study, as you were mentioning, that there is a higher chance of developing a frozen shoulder. The odds ratio of developing a frozen shoulder post menopause is 98% as compared to a woman who's not menopausal. However, that is just an association, just like diabetes and hypothyroid patients, which means that all menopausal women or all diabetics or all hypothyroids will not develop a frozen shoulder. But there can be an increased chance of you finding diabetes, thyroid, or menopause in a patient who has a frozen shoulder. So when this patient lands up in my clinic, my first assumption or point to prove to the patient or to find the cause is these rotator cuff injuries. So an MRI is extremely helpful. When the patient presents, there are two things we look for. All of them present with shoulder pain, but when I see and ask them that was what was the cause, number one is the history. If they give me some history of injury, yes, it points my brain towards them having some injury. But if they don't, then the first thing I ask is, can you do your bra for a woman? So if she says I can't, then that's the first movement that gets restricted. The second is, can you uh, put a clip on your hair? And she says, no, I can't reach. It's difficult. I mean, I'm not able to reach the behind my ear. And then the third and the final one, when the patient's become extremely stiff, is I can't elevate my arm, and that's becoming tight. So a patient who first complains that I can't do my bra and can't go behind my head is the one we do MRIs for. And once the scans tell us that there is no injury, that's when I start believing that, yeah, this is an idiopathic frozen shoulder. And mind you, these types of idiopathic frozen shoulders will improve. It is just a matter of time. Takes generally between 1 to 2 years for their range to improve and slowly, function. And If they don't, then there are more treatment options.
Is the timing of seeing a specialist important? Like you mentioned, a woman who can do simple tests. Like these are things that one can check at home, right? I can't put on my bra, or I can't put my hand overhead. Is that an early sign that I should be seeing a physician instead of sitting on it? Can early treatment help improve her range of movement, or it doesn't matter when she sees you?
So the first thing they will present with is pain on stretching. So if they find that they can't do it and it's painful, and slowly it's worsening, and they are doing their stretching but it's not opening, it's quite painful. That's the time, yes, that's an early sign, and we need to intervene at that position or that point in time. Because once this is a sign of early inflammation that patient has presented with. If we take care of the early inflammation, this patient may not land up into a complete stiff shoulder, but it does not guarantee it. There is a progression to this disease, and the inflammation, if taken care of early, possibly prevents the further progression of stiffness, provided there is no injury. If there is an injury, then the worsening is sort of guaranteed, in which, if they pushed it or still kept exercising on a broken rotator cuff, there's no question that that pain is going to worsen, the stiffness is going to worsen. So if there
Mm.
is no stiffness, no pain, at that point we intervene with either pain medications or anti-inflammatories or steroid injections or something that reduces the patient's pain, and they can then stretch. So most important thing to do here is to keep stretching or keep moving your shoulder. The best exercise in this case would be to get into the pool. The simplest thing of just getting into the pool and just moving your shoulders with the buoyancy of the water helps it really well. It relaxes the muscles and it improves the range. And that can prevent them from developing more stiff shoulders. Of course, the metabolic side needs to be looked at, and if there are any confounding factors that way, then they need to be corrected too.
You mentioned, sarcopenia a few minutes ago, and sarcopenia is basically low muscle mass, right? And menopause, we know that the decline in hormones also leads to sarcopenia or low muscle mass. Considering women are usually less active with lifting weights, do you see that as a contributor to injuries or to frozen shoulder, idiopathic frozen shoulder, or what are your views on that?
I mean, there's no question that unless there is some sort of resistance put on your bone, anything you consume is not going to help build it. I mean, it's like a one-way pipe. It's just going to go from your mouth and come out your bottom. It's not going to go into your body unless you load the muscle or load the bone. So the first thing is whatever amount of protein you consume, if it's supposed to build your body, you need to exercise, and there has to be a need for your body to then regenerate or regrow. If your body feels there's no need for me to regenerate, it's not going to regenerate. So you have to stress it. There has to be some stressor for it to increase. And uh, there is no question that osteopenia or osteoporosis sets in because of lack of exercise and lack of resistance training. So unless there is resistance given to the muscle, everything is going to go down the drain, and you're going to age faster. You're going to notice that your muscles go limp and everything is hanging, and then you feel, oh, I'm getting old. So unless resistance training is the only thing that's going to save you from the wrinkles and the uh, what do you say, the loose skin that you feel, I guess. But they must impress upon this that all women nearing menopause, there is no question that unless you did this, you are going to age not gracefully. You have to age gracefully, and resistance
Uh,
training is a must.
Resistance training is a must. Will it prevent me from getting a frozen shoulder?
I,
Because the other
I
thing
don't
is
think so.
also, mm,
I
mm,
don't think resistance training prevents you from getting stiff shoulders,
mm,
but uh, uh, lack of stretching exercise probably will. So
mm,
you need to stretch as well. There has to be a routine where you are doing your stretches, especially for the shoulder. I mean, the shoulder is the most mobile joint in the body. There's no question. It
mm.
rotates, revolves, glides, everything. So unless you stretched there is a possibility it may become stiff. Obviously, you cannot do excess, in the sense if you did something that has caused an injury, you will develop stiffness in your shoulder, because it will then try to protect it and guard, and then that will become a frozen shoulder. So what I notice in my patients that come in like this, especially who are active and develop pain and shoulder stiffness, is that there's one terrible exercise of stretching that the gym trainers love to do, where they put your arm behind the back and try to squeeze your arms, bring them all together. I think that's an abnormal movement for the shoulder. You're just doing too much when you move your arm back and then going to push it behind. You're just pulling the rotator cuff in its most unnatural position. That's just going to overstress it, and that is what is going to cause some sort of a small injury, or begins with tendinitis, which means early inflammation in the tendon, and then that will lead you to develop a frozen shoulder. So stretch, but not too much.
Wow. I've seen a lot of people having that done by their trainer at the gym, and it's good to know that it's not to do. So thank you for sharing that. So ladies, let's not get overstretched at the gym.
That's
Um,
true.
okay, having said that, what are the prevention and treatment strategies? Is there any way of, okay, you mentioned a few metabolic conditions. Maybe you said the pain can come lower if those are taken care of. Are there any prevention strategies for frozen shoulder? And then what are the treatment options if one has already developed a frozen shoulder?
So I think prevention, we've already mentioned that you need to stretch and
Yeah.
exercise and be active, correct your metabolic disorders, be in general healthy. Uh, Beyond that, in terms of treatment, once you develop it, then the first thing is there will be inflammation in the early stages. The frozen shoulder, if you go by the book, goes into three stages: the inflammatory stage, and then the stiff phase, and then the thawing phase, where then it slowly improves. And it is a self-limiting condition in which, if there is no injury and it's an idiopathic frozen shoulder, it will improve over a period of time, need stretches. So the first thing is exercise. You need to stretch it, but the pain has to be managed, in the sense if you stretch and it's too painful, you won't stretch and then remain stiff.
Mm.
So the pain management is most important in the early inflamed phase, which is generally between 3 to 4 months once you start developing a stiff shoulder. At that point in time, the pain management can be as simple as just taking a Panadol or paracetamol, the simple medications that is in general not going to be very harmful, and then continue to stretch. Beyond which, you can take muscle relaxants and get an occasional massage done to relax your muscles, take a warm water bath before you stretch, and that helps. Uh, but then eventually, if that none of that helps and you're in excruciating pain, sometimes a small jerky movement brings you to tears with this type of a stiff, painful shoulder. At that is the patient who I will advise to take a steroid injection. A steroid injection given the right space, either in the bursa, which is the space between the bone and the muscle, and in the joint where the inflammation sets in, helps significantly in the patient's pain. But it does not help tremendously with the patient's stiffness, in which once the patient comes to me saying that I am 3 to 4 months and I am stiff, it's very important for them to understand that giving this injection is not a magic cure where it will solve it overnight. It will make them more tolerant to exercise. So there is no question that these patients need to then move on to exercise. When do I suggest surgery for these patients? This is a very rare subset of patients who we've tried everything and their lives are miserable, in which they can't function at all and they need to function. Those are the patients. Then we do an arthroscopy at the end of 6 months if they have not responded to any of these treatment medications. Now, doing arthroscopy is the latest and greatest intervention for a frozen shoulder, where we are releasing the tight, stiff structures under vision. So we know that we are not touching your muscles, we are not touching any other vital structure around your shoulder. And it's much safer and sort of predictable that I will be able to deliver on bringing your movements back. The recovery out of this is quite fast and dramatically improves the patient's outcome in the short term, and then they have to strengthen or bring back their muscle strength back to where it was, and then that has proven in the sense, arthroscopic release on a 7-year follow-up studies have found minimal, like about a 99% patient success rate, where they have not developed their stiffness again at the end of 7 years still. So it's a very effective way of managing these patients. There was a yesteryear's treatment and still is being used, something called as manipulation under general anesthesia. It is successful, no question, but it is a blind treatment in the sense anesthesia is given and then your movements, your arm is moved around so as to break apart those adhesions in a stiff shoulder. But then these problems are not addressed, in which if you have a small tendon injury, you have a small labrum tear, there's no way to solve that, and there is a possibility that these patients come back with pain and stiffness. So arthroscopic under vision treated is the best way to solve this problem eventually. If it's not possible for you to stretch it out and then wait around for a year and a half.
Is it possible, just out of curiosity, that something that doesn't show up on an MRI then shows up, false negative on an MRI, still shows up in an arthroscopy?
It's fairly rare in the sense earlier we used to do a diagnostic arthroscopy. I think there is no role for it anymore because the MRIs are 99.9% sensitive and specific in the sense we will see something. If it's there on the MRI, I will see it on arthroscopy. It's very rare that I find something which I don't see on an MRI. In terms of a structural disorder, obviously, in terms of a functional problem, let's say if there is a neuropathic problem in the sense a diabetic neuropathy, that you cannot diagnose on an MRI. So I mean that's a function problem. So any sort of a structure problem, we can definitely go ahead and treat it in this manner.
Right. Right. And how long does it take to recover? You mentioned in the early stages, inflammatory stages, please correct me if I'm wrong, one should still continue to move and stretch. Maybe you require some amount of over-the-counter painkillers or sometimes a prescription drug to control the pain, but continue to stretch. And if one then proceeds to become stiffer, then one may need further treatment, a steroid, or may require maybe even an arthroscopic procedure. If at very stages, let's say I take care of it at the very beginning, inflammatory stage, and I'm doing my stretches, how long can it take me to recover? On average, I'm sure there'll be like variability, as opposed to later on, and what impacts that recovery? What makes it better or worse?
Yeah, so I think with us, once you develop a stiff shoulder, patience is the name of the game. In the sense, if you have to be patient with the disease, you have to stretch it on a daily routine basis. It takes in general between 1 to 1.5 years for the stiffness to slowly resolve and for you to find relief with this problem, in which you are back to all your activities, normally doing everything and with full range of movement. The interventions, yes, do help, and once they are done, they do improve this condition quite well and quite fast and sort of permanently. I mean, there is unlikely that you develop any sort of complications with it. Having said that, I mean, any sort of an activity that is going to cause another injury is to be prevented. Any sort of jerky movements need to be prevented. You going into a crowded place and somebody gives you a high five and then you cry after that. I mean, that's something which is going to definitely worsen your problem. So avoiding these types of engagements probably will help. Any sort of sport activity at this point in time will obviously worsen your problem. But the most important thing I would say is when you are inflamed, please don't do strengthening exercises. In the sense, when you have an inflammation, it just means that your tendon is weak. At that point in time, if you go ahead and you pull and you push and do all those exercises to build strength on your shoulder, you're going to snap your weak tendon. And then that's a secondary injury that you've developed. And then it definitely needs us to go ahead and fix it. But if you stretch at that time within your limits and then slowly only you will be able to improve it, then you are on the right track where this will improve without any problems. So avoid strengthening exercises in the early inflamed stages. Once you have less pain and we've taken care of that, then you start your strengthening slowly to rebuild muscle.
Which brings me to the next question. Like a lot of women find all kinds of excuses to not do resistance training. It's just an observation that I've made. Like women would rather just go for a walk, maybe even do a little bit of cardio, but resistance training is something that we resist. So having said that, does this become an excuse? I have pre-existent, let's say I have pre-existent sarcopenia, my muscle mass is anyway very low, and it may or may not contribute to the fact that I've now developed a frozen shoulder or a tear because I've not been using my upper body. Now I've developed a frozen shoulder, and now if let's say for 6 months, 1 year, I'm told not to lift, is it for that long that I'm told not to lift? So my muscle mass now shrinks even further because I'm not using it. B, what if I start putting on weight thinking I'm not supposed to be doing this? What other forms of exercise can I continue to do so that it doesn't become a real weight problem at the end of it and create a metabolic disorder like diabetes?
I think there is a misconception in which when you mean lift weight means everybody thinks of a bench press. It doesn't have to be that. You can just climb your stairs, and climbing stairs is a resistance exercise for your lower limbs. So please do that. Do something which doesn't involve your shoulders. You can continue to do all the other resistance exercises that you were doing in the gym, or you probably are going to start doing in the gym. The other thing about women being resistant to resistance exercises is probably a cultural thing. I'm not sure if that holds true all over the world, but women feel if we do strengthening on our shoulders are going to become broader and we look like a man. It doesn't happen that way. So
I
if you tone your,
wish.
yeah, I mean, I don't know what you want to.
No, it's so hard to put on muscle mass
That's
at
true,
any
but you
age,
need
especially at menopause.
is
Yeah,
not just
yeah.
for a woman, even for a man. I mean, beyond 40, if you think that you're going to become a bodybuilder on that journey, it's very difficult. It's not that easy. So earlier you probably used to spend like an hour in the gym and that would be enough, but that's not enough then. So that goes both ways. I mean, the resistance training needs to be done for building muscle, but when you are suffering from a shoulder condition, especially, do not strengthen. I mean, you have to maintain a balance. The shoulder is a balance. You unless there is a balance maintained, you are either going to fall on this side of the cliff or that side of the cliff. So you have to walk that thin line where you can improve your condition without you getting injured. So uh, patience and balance.
And you mentioned that usually, a year and a half, is that how long it can take to sort of go back to pre-injury, pre-frozen shoulder
Yes.
situation? So then it's like, as you mentioned, it's that waiting game that it's not a dead end that you will not be able to exercise again, right? You at some
So
point
this is what
will be.
I impress upon my patients in my consulting as well, that you're not suffering from a terrible disease where there is no light at the end of the tunnel. This will improve. When the patients come, they are in extreme amount of pain and they would grab onto anything that you throw at them to give them relief.
Mm,
So this counseling is extremely important. And then there is a cafeteria approach. I mean, there are so many treatments that are possible for this, and each with its effects and side effects and no effects and things like that. So we have to sort of treat the patient, not the scan. And I need to understand what's the requirement of the patient. If the patient tells me that, doc, I'm mostly sedentary, I don't do any overhead activities, I just want pain relief, I'd give him that or give her that. If the patient says, no, doc, I need to go play throw ball or do something and I have a very stiff shoulder, I have the option to then do an arthroscopy and get her back to normal faster.
mm.
So it's the patient's choice. Our job as shoulder surgeons is to approach a patient on their needs. Uh, I know that if I do an arthroscopy for this patient, yes, they will improve. But unless the patient wants it, I don't deliver.
Mm. Well, that's a great approach, and um, looking at the patient and not looking at the scan. So what is it that the lady? I'm going to talk about women over here. I'm sorry, I'm biased. But what does the woman want to achieve at the end of this? But I'm hoping that every woman wants to do some resistance training at the end of this.
I
For
want all women to do resistance training to
Yes.
build strength on themselves. You are not going to become broad-shouldered man. Please do some exercise to strengthen your muscles. That's the only way you will strengthen your bone.
Yeah, yeah, yes. That's the big message in every podcast. Please, let's do some movement and exercise. Now, coming back to the frozen shoulder, are there any misconceptions about frozen shoulder that you know go, go through in your practice? Women asking questions or believing in things that are not true medically.
Yeah, so it's interesting. Like for everything that is labeled as idiopathic, there are extreme kinds of treatments that people have gone through or have tried to solve it with, and people have achieved varying degrees of success or failures with them. Uh, the most interesting thing is with a frozen shoulder, the doctor who they saw last at the end of 1 year gets the credit that this fellow solved my problem because it will take that amount of time. And I see so many patients coming to me, seeing so many specialists, and then at the end saying that, doc, you are telling us the same solution that the previous one said, because there is no other solution. I mean, this is the only way this problem will get resolved. In terms of patients having superstitions, oh my God, people can have any sort of superstition. They would say, I fell in my childhood and now I've got a stiff shoulder. Is it because of my karma that I got this? No. So it's not something that, because, and a lot of people are scared, is this cancer, because it's extremely painful in
Yeah,
these types of conditions, and we have to prove it to them that this is not,
yeah.
and it's not really that serious of a condition.
So we have someone asking, could you tell us that, how do you differentiate between a frozen shoulder versus a cervical? Is there sometimes a
Yeah,
confusion between the, yeah?
yeah. So cervical pain will give you tingling numbness in your arm. The first symptom you will feel is pain in your neck. The pain will radiate down your arm, and pain in the shoulder rarely travels below the elbow. Uh, but cervical pain will travel all the way down your arm. If you're feeling weakness in hand grip, if you're feeling tingling numbness in your arm, and your main complaint is stiffness in your neck, then that could be a cervical spine pain. A cervical pain often can be bilateral or in both your shoulders, but shoulder pain will either be left or right. And yes, I treat both left and right shoulders. I'm not yet that
Well,
specific.
super specialization, you never know.
So yeah, so cervical pain, this is the way it's differentiated: neck-related stiffness or neck movements, having radiating pain down the arm, going all the way down the fingers, and then some tingling numbness. And yeah, I mean, it's we always share patients, like shoulder specialists refer to as spine
Right,
specialists and vice versa.
right, right. It's amazing how super specialized we have become. But sometimes it's important to look at the whole woman as is as well,
That is
where,
true.
yeah, yeah. But okay, so there was someone else who said, I have shoulder pain, but I'm not being able to stop my weightlifting. What is your advice to someone who's saying this? पता है इंजरी है पर मुझे बंद नहीं करना है. So now what how do you console them or counsel them?
आपको मेरी जरूरत जल्दी पड़ेगी. So मेरा नंबर ले लीजिए.
Which we will share at the end of this. But well, that is nicely put, and I think that is it's almost self-destructive when one knows there is an injury and still continuing to
Absolutely.
injure the, yeah, okay. Okay. Do you have any memorable case or a success story that you'd like to share with us?
So it's, I mean, all patients, I'll speak about patients having stiff shoulders, and especially women with stiff shoulders. They finally have a sigh of relief in on their face the next day when I go and see them after a capsular release or an arthroscopic release. The first thing out of anesthesia, once they come out, they wake up with their arm completely up. And the first thing I ask them, how long has it been that you haven't been able to scratch your other ear? And they're like, wow, I can reach there. so,
Well, it
so
can be. Yeah, sorry, go ahead.
yeah, so pretty much all women who will go through this will experience this relief, and it's amazing how they get back to all their activities, and that's what keeps us or keeps me going. I mean, that these patients do find relief at the end of this
Yeah,
struggle, some long journey, and a lot of people go through a lot of treatment options before they reach to this stage where they say, "Doc, please do it for me. I mean, this isn't
yeah.
improving at all." And then once they find the relief, there are. I mean, my cupboards are loaded with gifts with it then.
Well, so as you mentioned earlier, it's not a life-threatening situation, and you said, oh, it's not serious, but I've suffered from a frozen shoulder, and I feel I thought my life was falling apart. Not being able to put on your clothes, not being able to, like, fortunately, I don't have hair to comb, so that wasn't a problem. But not being able to do the small things, and I had little kids at that point. It was debilitating.
Yeah,
Um,
you're not
so I
alone.
feel,
I mean, this is
yeah, yeah,
exactly
yeah,
what women go through and they feel, and I don't know why they choose to suffer.
yeah,
They choose this route of them going through this pain, as if that's going to make them stronger.
yeah,
It,
yeah,
I mean, there are solutions to this now. So, I mean, there is an option and there is a possibility that you're going to get better, provided you choose to take that route.
yeah.
Uh, Diagnosis is the most important thing, so you have to be patient with your doctor as well. Let us diagnose it correctly and then put you on the path to getting rid of this problem.
Yeah, but like I feel that there's also the other aspect. Like if someone is told to take an injection in their joint, do you face any resistance over there? Because when you say the word steroid, someone like me who had a medical background was still thinking, "Oh my God, is this going to impact me in the long run, taking a steroid in my joint?" So is that something that you face?
Very
Questions around
commonly,
steroids? Yeah.
very commonly, and I only offer that option to a patient who's extremely painful. Uh, unless they are that painful, the steroid is not going to do anything for them. In the sense, if you did not have pain and I gave you a steroid, it's not going to benefit you even 1%. I mean, it's no point giving you that. There is a lot of resistance from women because they've heard a lot of things, and everybody goes on Google before they, find any sort of intervention that needs to be done on them. And you will see a lot of side effects written about it, and there are definite side effects to taking a steroid injection, but it is much more safer than you taking oral steroids. You taking oral steroids are prescribed left, right, and center. Everyone who comes to my OPD had with a stiff, painful shoulder has been on oral steroids, them with or without them knowing it. That's the
Wow.
sad part about this, is that it's just prescribed over the counter, and there are weight gain problems if you take it on a long term basis. There is diabetics. I mean, your sugar levels will rise, and you'll have acne issues and a lot of skin problems and things like that. So taking a steroid injection is far safer than you taking oral steroids over a long period of time. Having said that, a steroid is a steroid. So some patients will experience some sort of a hormonal imbalance in their body or especially women who are nearing menopause, because all of these women are in their near menopausal age. So they do experience some sort of changes in their menses. Either there can be change in the frequency or the flow. And I have experienced women who have taken it complaining of this, but it is all self-limiting. In the sense, in a couple of cycles, it does return back to normalcy, or if you are perimenopausal anyway, I mean, you're going to go through that. Very rarely have I found a postmenopausal woman complain of a bit of spotting, and that has been alarming for that patient, wondering that do I have some sort of an endometrial problem? Is it endometrial cancer? That's why I'm getting this spotting, and that needs to be investigated whether that is a problem. But a steroid does give rise to some patients having menses issues or hormonal imbalances on a short period of time.
A
So
short
that's
period
where
of
the
time,
resistance.
right? Right.
So that's where the resistance comes in from, and once I explain this to the patient, then they are aware about it. Once they're aware about it, they're not scared anymore.
Right.
So
Right.
awareness is key.
Right. Well, that's great to know, especially in perimenopause. Anyway, one can undergo cyclical changes. The cycles can start to get erratic. So sometimes it can be confusing. Is it the meds, or was this normally happening? Was this going to happen to me anyway? And I hope over time we have more data on um, menopause, perimenopause, and its relationship with frozen shoulder, and perhaps even on hormone therapy and frozen shoulder. Right now, the body of evidence is really small, but I hope with time we do have more things to support it and help us prevent
I
it.
think
And
the
maybe then we'll have
onus
to visit
is.
you less then.
I wish, I really hope so. I don't want to work this much.
Well, that's good to know. That's good to know. Any takeaways, final takeaways for our listeners? Make it women specific because that's our big bias.
Uh, don't be afraid when you have pain in your shoulder. Get it diagnosed. Just don't think that any pain in my shoulder, this is a frozen shoulder and this is going to take years together. Do not do strengthening exercises when you have pain at a particular point that may worsen your problem. Please do resistance exercise to build muscle and build bone, and stretch.
Yes. All right, wonderful pieces of advice. Please, everyone, take these pearls of wisdom back with you and listen to the doctor. I wish exercise came in a prescription. That would be probably the best thing ever.
But that
But
is something that we prescribe now. Exercise
that
is
is
medicine.
great. That is great. That is great. So thank you so much for sharing all your wisdom with us because we need it. We need strong shoulders, and it's been amazing just speaking about frozen shoulder. So different looking at it from a menopausal aspect. But it's been amazing chatting with you. I hope everyone has learned something. I'm sure everyone has learned something out of this conversation that we're having today. And,
Thank
well, thank you. We will be sharing, for those of you who'd like to consult Dr. Desai, we'll be sharing his contact details so that you can fix an appointment and fix your shoulders. So thank you again. Thank you very much. Thanks again for tuning in to MenopauseWize. Stay informed, stay empowered, and I'll see you in the next episode as we continue to navigate the menopause journey together. If you're a healthcare provider interested in collaborating with us or have insights to share, we'd love to hear from you. Please email us at info@menopausewize.com. That's wise with a Z. And before we go, a quick medical disclaimer. The information provided in this podcast is for educational and informational purposes only and is not intended as medical advice. Always consult your physician or a qualified healthcare provider before making any decisions regarding your health or any medical treatments discussed in this podcast. While we strive to provide accurate and up-to-date information, this podcast does not replace professional medical consultation, diagnosis, or treatment. If you have any concerns or symptoms that require medical attention, please seek advice from your healthcare provider.